All right, welcome to The Explainer. In oncology, time is always a factor, but sometimes it becomes the only factor. So today, we're going to jump right into a rapid review of oncological emergencies. These are those acute, life-threatening events where spotting something and acting fast, that's everything. It can be the difference between reversible damage and permanent harm. So let's start with the basics. What are we even talking about here? Well, an oncologic emergency is basically any sudden, potentially life-threatening event that's linked to a patient's cancer. But here's the key thing to grasp right away. These emergencies can pop up from two very different places, either from the tumor itself or from the treatment we're using to fight that tumor. And understanding that difference, that's our foundation. It's how we start to predict what might go wrong before it does. Okay, here's how we're going to break this down. First, we'll really define the crisis and its pathways. Then, we'll get into the big categories: structural crises, then metabolic and treatment-related crises, and then how to handle malignant fluids. And we'll wrap it all up with the one big takeaway you absolutely need to remember. All right, section 1, let's define the crisis. And really, it all boils down to two main pathways.
Think of this as your mental cheat sheet. It's so important. On one side, you've got problems caused by the tumor just being there. It's physical bulk, like spinal cord compression. It's a mechanical issue, right? A tumor is literally squishing something critical. Then on the other side, you have problems caused by our treatments. Think of something like Tumour Lysis Syndrome. This is a metabolic crisis. It happens when the treatment works so well, so fast, that the system gets totally overwhelmed. Having these two buckets in your head is a game changer for anticipating what kind of trouble you need to be looking out for.
Okay, let's dive into that first bucket. Section 2, structural crises. This is where the tumor's size and location are the problem. And we're going to start with probably the most classic and maybe most feared of these: spinal cord compression. Okay, so this is huge. If you have a patient with one of these three, lung, prostate, or breast cancer, and they show up with new back pain, or their existing back pain is getting worse, man, alarm bells should be screaming in your head. Your suspicion for spinal cord compression needs to be sky high. These three are the absolute classic culprits. And you gotta remember, that back pain, that's just the first domino. From there, it's this awful, predictable march. Pain leads to weakness, which leads to numbness or sensory loss, and the final stop is loss of bladder and bowel control. The window to stop this is incredibly small. So what do you do the second you even suspect this? You have to move. First thing right away is high-dose dexamethasone. That's to shrink the swelling around the spinal cord and buy you some time. It's step 1, no delays. And at the same exact time, not after, simultaneously, you're on the phone getting an urgent consult. This is a team sport. You need radiotherapy or surgery, and you need them involved like yesterday. Okay, let's look at another one of these compression crises: superior vena cava obstruction, or SVCO for short. What's happening here is a tumor in the chest, usually lung cancer or a lymphoma, is literally squeezing shut the big vein that brings blood back from your head and arms to your heart. The result? It's like a traffic jam. All that blood backs up. You see this really classic picture, a swollen, red, puffy face. We call that plethoric. And you'll see the jugular veins in the neck just bulging out, and they won't be pulsing like normal. Now, pay close attention to this, because this is a super common mistake, a real clinical trap you can fall into. You see all that swelling, that edema, and your brain immediately thinks, diuretic, let's get that fluid off. You have to fight that instinct. Do not do it. Why? Because that blood is already moving super slowly, it's static. If you pull fluid out of the system with a diuretic, you're just making the blood thicker, sludgier, and you dramatically increase the risk of a massive blood clot, a thrombosis, which would be, catastrophic.
All right, section 3, we're shifting gears now. We're moving away from the physical, structural problems and into the world of metabolic and treatment-related crises. This is about chemistry gone haywire. And we'll start with a big one: Tumour Lysis Syndrome.
So what is Tumour Lysis Syndrome? Well, lysis means to break apart. And that's exactly what's happening. Our treatment is working, maybe a little too well, too fast. It's causing tons of cancer cells to burst open all at once, and they spill all their insides into the bloodstream. And that flood of junk just overwhelms the body's systems. You get sky-high uric acid, which can wreck the kidneys. Potassium skyrockets, which is terrifying for the heart. It can cause a fatal arrhythmia. Phosphate goes way up, and as it does, it grabs onto calcium, causing calcium levels to plummet, which can lead to seizures. It is a complete metabolic meltdown. Okay. Another classic treatment-related crisis, febrile neutropenia. The story is simple. Chemo has wiped out the patient's white blood cells, their neutrophils. They have no immune system, so if they get a fever, you have to assume the worst. A fever in a neutropenic patient equals sepsis until you can prove it's not. And because of that, everything is about the clock. As you can see, the clock starts ticking the second that fever hits. Within the first hour, you have to have broad-spectrum antibiotics on board. You don't wait for anything. Then, if after 3 days, 72 hours, they're still spiking fevers, you have to think, okay, maybe this isn't bacterial. Your suspicion has to shift to a fungal infection, and you add an antifungal. All right, on to section 4, managing malignant fluids. This is a really common problem you'll see with advanced cancers, basically fluid building up where it shouldn't. So what happens is the cancer irritates the delicate linings of our body cavities, and those linings just start to weep fluid. When this happens in the chest, around the lungs, it's a malignant pleural effusion. The patient gets short of breath, and when you examine them, you hear that stony dullness when you percuss their chest. When it happens in the belly, it's malignant ascites. You see this huge, distended abdomen, and you can get that classic fluid wave on exam. Okay, so here's a question that trips people up all the time. You do the right thing, you tap the fluid, you send it to pathology to look for cancer cells, and the report comes back negative. So you're in the clear, right? It's not the cancer causing? The answer is a resounding absolute no. A negative cytology result is honestly more misleading than helpful sometimes. It's only positive in about 1/3 of cases. That means 2/3 of the time it'll be negative even when the cancer is the cause. So the clinical rule of thumb here is basically written in stone. If you have a patient who you know has cancer and they develop a new effusion like this, you have to assume it's from the cancer until you have definitive proof that it's something else. Okay, section 5. Let's bring this all together. The big takeaway. We've talked about compression. We've talked about metabolic chaos. We've talked about fluids. But all of this, it all points to one single, incredibly important principle. This right here, this is the scary truth that sits at the center of all these emergencies, but especially with something like spinal cord compression. Nobody knows. No one can tell you the exact moment, the number of hours or minutes when reversible damage becomes permanent, when a patient goes from being able to walk again to being in a wheelchair for life. That line in the sand, it doesn't exist. We can't see it. And that terrifying uncertainty, it leaves us with only one possible conclusion. One rational course of action. It's the most important rule for every single thing we talked about today. You have to treat it as fast as you possibly can. Because we don't know where that point of no return is, our only weapon, our only defense is speed. In these situations, time isn't just a factor, it's everything. It's function, it's quality of life, and sometimes it's life itself. Thanks so much for joining this explainer.